Thank you so much, everyone, for having me here today. Especially thank you to the Macular Society for putting on this amazing annual conference. My name is Kenneth Fan. I am a United States-based retina specialist and inherited retinal disease specialist, and I have the honor of discussing with you guys today about inherited retinal diseases and specifically Stargardt disease, which is a macular dystrophy, a hereditary macular dystrophy. And we're going to talk a little bit about these diseases and what the treatment horizon looks like, the future of research and therapy in hereditary retinal diseases like Stargardt. I work at an all retina based practice in Houston, Texas, in the United States. It is a large practice. Texas is a big state, so we have to cover a wide area with lots of patients. I have the privilege of being the inherited retinal disease specialist for my group. So we see all sorts of macular diseases and also surgical retinal diseases as well. And I see all of the inherited retinal diseases, of which there happen to be very many. I just want to start my presentation off by talking a little bit about what my clinic might look like on a day-to-day, and the contrast between patients that are seen sort of in a regular day-to-day retina clinic as compared to that which I might see in my clinic, where a patient might have something slightly atypical that isn't your run-of-the-mill, age-related macular degeneration. So this slide depicts two women, one slightly older, one slightly younger. And on your left side of the screen here, you see Miss A. Miss A is a retired, healthy 60-year-old female, and she's just going for her regular, optometric or ophthalmological annual eye screening. So she goes in and the doctor sees her and says, well, you've got some changes on your retina, and I believe you have age-related macular degeneration. So this is a very common story. Many of us are familiar with this, and many people have age-related macular degeneration. On the right side of the screen, you have Miss S. Miss S is a healthy, working 45-year-old female. And she's undergoing just a regular annual eye screen as well, getting her glasses. And her doctor also notes some similar findings on her dilated exam. And they look inside and they say, well, it looks like you have macular degeneration. And so she's a bit confused because she knows that macular degeneration is typically age-related, but goes along with it. So Miss A, the first patient, over the next 5 to 10 years, is being told that her AMD is slightly progressing. Every year it gets a little bit worse. Maybe it might convert from dry to wet. She might develop what we call geographic atrophy, which is an advanced form of AMD. And luckily, there are many FDA-approved therapies that can treat Miss A. Miss A is able to get treatments of injections in the eye for wet AMD. In the United States only, there are available treatments for geographic atrophy, which is the advanced form of AMD. These injections aim to slow down the progression of geographic atrophy over time. I know these are not available in the UK yet, but suffice it to say, there are many treatments that are FDA approved for the treatment of age-related macular degeneration. So by age 70, Miss A is still seeing well. She's seeing 20/20 in both eyes and able to maintain pretty good vision. On the flip side, you have Miss S, and on the right side of the screen, Miss S, you can see here, is being told that her AMD seems unusually aggressive. And over the next 5 to 10 years, Miss S becomes legally blind. She's unable to really see clearly in her center vision. Her AMD appears to have created lots of blind spots and blurry central vision. She's unable to drive, work, and is now completely dependent on her family. And the treatments that were applicable to Miss A for her treatment of AMD are not applicable to Miss S, because Miss S is eventually diagnosed with Stargardt disease. And Stargardt does look very similar to AMD, but it is hereditary in nature and is more aggressive in that it starts much earlier in life, and there is no treatment for Stargardt disease. And this presentation is a very common one that I get in clinic, where patients come to me and they're quite young, working age, even teenagers, and these patients are unable to figure out what they have because they've been told that they have macular degeneration their whole lives. So Stargardt disease, we'll get into the details of the disease itself, but there's a very broad and significant impact, at least in the United States, and I know also in the UK as well, for this disease. So the numbers have been told to us as 1 in 1,000 to 1,500 people have some form of a hereditary disease across the globe, and especially in the United States. And so we believe that this encompasses all inherited diseases, not just Stargardt disease, but other IRDs like retinitis pigmentosa, for example. And one of the biggest impacts of a hereditary disease is that it affects your physical health. So it makes it hard to navigate and to walk in dimly lit conditions, even in daytime conditions. And we frequently have patients, falling, having accidents, and hurting themselves, ending up in the hospital. There's also a massive mental health burden. This mental health burden um, is increased by 2 to 3 times for conditions like major depression and debilitating anxiety. Just to give you a sense of how common 1 in 1,000 people is, and I think it's hard to really think about these numbers in a realistic way, but there's other very well-known conditions that have a prevalence of about 1 in 1,000, and these include autism spectrum disorder, cystic fibrosis, Down syndrome, and BRCA1/2 mutations in breast cancer. So these are a little more commonly discussed conditions that may be in the news more often, but IRDs fall into that category of rarity. There's also massive societal impacts of inherited retinal diseases on the system. At least in the United States, we know that these patients end up frequently visiting the doctor. They have lots of diagnostic testing because patients are unable to figure out exactly their diagnoses. They end up on many medications. For the eyes, this might include erroneous injections in the eye for conditions that they don't actually have. Hospital admissions, of course, because the IRDs affect patients of working age, younger patients, they end up being a lot more likely to be unemployed or to miss work. There's significant burden on caretakers who have to bring them to and from visits and sacrifice their own work-life balance in order to bring these patients to the doctor. And there's also, in a health economics way, very high calculations of what we know to be disability-adjusted life years, which are years of life that are impacted or lost due to patients living with a disability. So before we dive into the rest of the presentation, I just wanted to go over what the retina actually is. And many of you may already know this, but the retina, what we have here on the screen is an eye, a 3D model of an eye. And the eye, if you look inside the eye and you look all the way on the inside, all of that orange red tissue on the back of the eye, which is almost like the wallpaper on the wall of the eye, is called the retina. And the retina is the neurosensory organ that helps us see light and process light. And inherited retinal diseases are a group of hereditary diseases of the retina that cause symptoms that range in all severity. So you can have patients who have an IRD that are minimally affected, and then you can have patients who are massively affected. And by definition, we know that they are genetically passed down from either one parent or both parents. And there has to be some sort of variant or mutation in the genes in order for a patient to actually have an inherited retinal disease. So there's a very large range of symptoms I discussed before that makes IRDs difficult to diagnose and to detect because patients with these IRDs can present very differently. In the United States, the prevalence of IRDs is around 400,000. There's over 4 million globally, and scientists have detected over 300 different genes, and surely there are more that can cause an inherited retinal disease. The most common IRDs we know of are, number one is retinitis pigmentosa. I'm sure you guys have heard of this before. Stargardt disease, which is more of the topic of our discussion today. And then there's other more rare diseases like Best vitelliform macular dystrophy and cone rod dystrophy. And when you break it down by diagnosis, retinitis pigmentosa is the most common. But when you break it down by gene, you actually find that the gene that causes Stargardt disease is the most common genetic variant detected in inherited retinal diseases, followed by some other mutations that cause retinitis pigmentosa, for example, USH2A, EYS, or RPGR, and then the Best vitelliform macular dystrophy gene, which is caused by BEST1. So these are all, as a clinician, these are the genes that we kind of look for when we do genetic testing on patients who might have an inherited retinal disease. So this slide's a little busy, but basically what I'm trying to discuss and display on this slide here is that the visual cycle can be affected dramatically by a single mutation in your DNA. On the left-hand side of the slide, you have the actual visual cycle with proteins and the interaction of certain cellular membrane proteins and light kind of coming through and going through its visual cycle. And on the right, you have a depiction of an assembly line. And it basically works in a very similar fashion where if your eye has a genetic mutation where the retina is unable to process light, that light byproduct is unable to go all the way through and transmit signals back to your brain. And so something breaks down in the middle of that assembly line, and those proteins build up and build up and build up, and they actually end up causing damage to the eye. And the same is true for an assembly line. If there's a machine or one part of the assembly line that's not working well, then the product cannot go all the way through, and you don't end up with a properly finished item. And so both are somewhat similar. And so essentially that's what happens in these diseases like retinitis pigmentosa, RP, and Stargardt disease. So we'll first talk about RP. RP is the most common inherited retinal disease worldwide. We know that over 100 different genes can cause RP, and the hallmark symptoms of RP are loss of night and peripheral vision. And so here's a image of that retina that we talked about before, and essentially this black area, so this is all of the peripheral retina, is what gets affected in retinitis pigmentosa. As a patient view, you can see a depiction of a picture here on the screen where you're looking at, a nature scene, and you can see that as RP progresses over time, you start losing more and more and more of your peripheral vision. And this is maybe what someone with severe stage retinitis pigmentosa would see on a daily basis. Stargardt disease is quite the opposite, actually. So Stargardt disease has an incidence of about 30,000 people in the United States. In the UK, it's maybe around 6,000. There's many patients diagnosed every year as genetic testing becomes better and we have more awareness over this condition. It's caused by the ABCA4 gene, as we discussed before, and the hallmark symptoms for Stargardt are loss of central vision and blind spots in the center vision and visual distortion. So unlike RP, Stargardt affects that center part of the retina. So again, looking at that retinal depiction, you can see the black area in basically the macula, the center vision. And so here on the screen, we have a picture of basically what looks like maybe like a lunch party or a birthday party, and you're looking at this table, and essentially in Stargardt disease, you basically start getting mild distortions in the center vision, and it gets bigger And then in end-stage Stargardt, it encompasses all your central vision. And I've been told that this is very similar to what it looks like in macular degeneration as well. So let's, take a trip back to Miss S, which is our patient who's living with Stargardt disease. What does life sort of look like for her? We know that, she has difficulty getting to and from doctor's visits, so she needs help with that, either, state or government provided assistance, or maybe her family who have to take time off to take her to the doctor. There's difficulty in the workplace, so she might have to leave her job or find a new job, or be unemployed. There's a lot of risks to her physical health and frequent accidents, and she's highly dependent on visual aids and low vision assistance, which might include things like a cane, or a guide dog, or visual devices that can project things onto a larger screen to help her be able to see and read, which can be very expensive. Just very quickly, we know that the economic burden, at least in the United States, is very high for diseases like Stargardt. So, it's estimated in this article that it costs the system $31.7 billion. And just for loss of well-being costs, so, physical health, mental health, up to $20 billion in the United States alone. So this kind of brings us to the importance of research and where we are right now for research for Stargardt disease. So in the past, there had never really been an FDA approved or government approved treatment for an inherited retinal disease until 2017, when the very first treatment for Leber congenital amaurosis, which is a rare inherited disease, was discovered. And this condition was caused by, or is caused by, a mutation in the RPE65 gene. And Luxturna, which is the medication that was approved, aims to replace that RPE65 genetic mutation by going into the eye and injecting that medication under and into your retina. And this actually was approved by the FDA based on performances of young kids before treatment and after treatment. So here on the screen, you can see a comparison of the same patient in the same room performing the same task in dimly lit conditions. And on the left, you have the patient before they were treated with Luxturna, and on the right, you have the patient after they were treated with Luxturna. And you can see as I play the video that on the left, the patient is severely struggling to navigate along the maze, along the path. And on the right, you can see that they are just breezing right through, able to step over obstacles and look at the arrows. And now you see that this very same patient who's post-treatment on the right is finished with the maze already. And on the left, the patient continues to struggle with being able to navigate the same maze. And so this video continues on for quite some time. As you can imagine, this patient is unable to really see. So this treatment actually changed lives significantly, and it continues to be a treatment for patients with RPE65 mutations. So that's for LCA, and so where are we with Stargardt disease? Stargardt disease is far more common, way more common. So why don't we have research available for this condition? So if you look at the website clinicaltrials.gov, you'll find that there are 12 active interventional, which are treatment-based clinical trials, and number of FDA cures or approved therapies, 0. And so, unfortunately, there's been some difficulty getting research for Stargardt disease over the past decade or so. And why is that the case? Well, there's 3 main reasons that I've identified that I think are really leading up to this challenge. And so one is that there's technological hurdles or difficulties in actually placing the gene into the eye. And so RPE65 the Luxturna medication had some easier, I don't want to say easier, obviously it was still very challenging, but technologically it was a little bit more simplistic than the ABCA4 gene, and we'll talk about that. We also know that ABCA4 gene can cause very different severities and presentations in patients, and so it's very, very heterogeneous and complex. And then capturing actual vision impairment and change over time is very difficult for ABCA4 and for Stargardt disease. Some patients may have may be impacted in their center vision. Some may be impacted just off to the side of their center vision. So, traditional approvable testing endpoints or tests that we do for patients are not always great for inherited diseases of the macula. So the first issue, technological hurdles, we know that prior therapies that have been approved can package the DNA into this hexagon here on the screen, and they can deliver that into the retina. But ABCA4 is too big. It's almost 50% too big, and so all of that technology that we've had and developed before in the past don't really apply to ABCA4. You can't just shove the DNA into a package that is too small for the DNA. So you could deliver half of the gene, but that would only apply to a select number of patients who have Stargardt disease, because if you only fix half of the gene, then well, if the other half has a problem, then it won't fix the problem. And so another approach would be that you could cut the gene in half and deliver two halves and then recombine them in the cell, which sounds just as difficult as I think it is, or is as difficult as it sounds. And there are 2 or 3 companies actually doing this right now in phase 1 clinical trials, but suffice it to say, it has been some time before the technology was developed. And then you could find other ways to deliver ABCA4 into the cell by finding a different package, so to speak, but that has not been validated before in the past, so it has to be reinvented. The second issue with developing treatments for Stargardt disease is that ABCA4 can present very differently in patients across the spectrum. So sometimes you have young patients who are 12 or 14 presenting with vision loss. Then you've got maybe 50-year-old patients who have pretty good vision and didn't realize that they even had Stargardt disease. And then you've got patients who present with total vision loss, maybe sometimes only central vision loss, only peripheral vision loss. So diagnosing Stargardt disease correctly is very challenging, and obviously it makes it harder to create a medication that applies to all patients. And the third one is a challenge for clinicians primarily, which is how do we test 100 or 200 patients with Stargardt disease and reliably detect if they can improve over time? Traditional methods of checking vision in, let's say, a clinical trial or in clinic is using the vision chart. So we tell patients that, oh, you see 20/20 or 6/6 or whatever it might be. But sometimes patients with Stargardt disease can see 20/20, but they can't really see much else. Just next to the 20/20, they have big blind spots. So how do we check those using a vision chart? You really can't. So then the question is, well, do we use a maze like was used in Luxturna? Do we use a visual field? Do we do it in dimly lit conditions, low luminance vision? So validating each of these tests that we do to reliably detect if patients are getting better with treatment or maybe they are not getting better with treatment is really important before we just decide, let's do this big clinical trial and submit it to the FDA and see if it'll get approved. So I know we've talked a lot about clinical trials and the research that's ongoing and the challenge of research. So briefly, I just want to show you, the different phases of clinical trials. Essentially, there's preclinical phase, which is in animals, and then there's safety, phase 1, which is primarily looking at safety, and then phase 2, which is when the dose is determined and you're looking at the early signs of efficacy of the dose, and then phase 3 you have basically a large-scale trial looking at whether the medication actually is beneficial to patients. And this is the pivotal trial where you submit for FDA approval, and then phase 4 is just monitoring post-approval. A lot of times in inherited retinal disease like Stargardt, phases 1 and 2 are combined to expedite the approval process. And the numbers, of course, are much lower. So you're looking at maybe for a phase 1, 2, only 10, 20 patients, and a phase 3, maybe 100 or 200. Across the spectrum, we have lots of clinical trials in multiple phases. So there's several companies in phase 1, 2. This is not an exhaustive list. There are more. And these companies are doing exactly what we're talking about, either delivering half of the gene into the retina for patients with Stargardt. You have companies combining two halves of the gene into one full copy. You've got two companies super exciting in phase 2 and 3. Alkeus Pharmaceuticals looking at an oral therapy to minimize or to mitigate the progression of Stargardt disease. And Belite Bio also is an oral treatment for Stargardt disease to slow progression. And so there's quite a few options out there, just waiting for development of the phase 1, 2 or phase 2, 3, and then approval by the FDA. This slide is a bit busy, and I know that, but essentially this is going back to the visual cycle. Each one of these, if you can see on the screen, these blue X's or blue crosses are potential therapeutic targets for Stargardt disease. There's a lot of people looking at, attacking the impaired visual cycle at all different angles in order to improve conditions of life and slow progression for patients with Stargardt. There's other, newer pathways as well. One that I want to talk about today, which is called optogenetics. Optogenetics is the injection of a medication into the eye for patients with severe stage Stargardt disease. There's a company by the name of Nanoscope working on this right now. And essentially what this treatment does is it delivers a light sensing molecule into your eye that can then sense light for the parts of the retina that no longer can do so by themselves. So in severe stage Stargardt, your what we call your photoreceptors are not really working anymore, so they don't really respond to light. And if you place these opsins, which are light sensing molecules, into the eye, they can turn on and off and hopefully sense light for these patients and improve vision. And that is the ultimate goal for patients with low vision. There's also people looking at metformin, which we know as traditionally a treatment for diabetic disease, to reduce inflammation and to improve retinal health in Stargardt disease. And we also, of course, know about stem cells, which are being studied right now to regenerate vision or to recuperate vision in patients who have lost vision from very severe macular disease. So in conclusion, research in inherited retinal diseases has advanced a lot over the last decade, yet there is still much more to be done. We don't quite have an FDA-approved therapy for patients with Stargardt disease, but I do believe that we are on the precipice and on the cusp of finding something. And so whatever we can all do to help the field advance, every little bit matters. And we know that there's a significant burden of disease for Stargardt disease on the community, on family, on patients. So we are motivated to make a difference. And so I really hope that you guys have learned something today. It was such a pleasure to deliver this message and to talk to you guys, and have a great day. Thanks.
Kenneth, that was absolutely brilliant. Thanks ever so much. That was very interesting. Just as a matter of interest, I do have Stargardt's myself. I've had it for many years, so I've got, one would say, skin in the game in this. So it's quite interesting for me, these kind of chats. So I've got a few questions for you. So my first one really is Miss S was diagnosed at 45. Your client, your patient B. So is that kind of the typical age? So what ages can we expect people really to be diagnosed with Stargardt disease?
It's a great question. The example was more to
to kind of contrast with patients who might be diagnosed with age-related macular degeneration, I would say age 45 is a bit later than your typical patient. Some patients are diagnosed in their early, teens or late teens, and some will be in their 20s and 30s. The challenge with Stargardt is that there's quite a wide range of presentations and symptomatic onset, so it makes it hard to diagnose accurately. But I would say 45 is definitely on the later end, and at that age, you might even consider it late onset Stargardt.
All right. Okay. Cool. So yeah, because most of the people that we speak to are sort of late. Well, they've had an onset, sort of late teens, early 20s,
Yeah,
as a rule of thumb. So
right.
yeah. Okay. I mean, I started personally when I was 8, so I've been doing this for a long time.
Wow.
Yeah. So, I mean, I suppose what leads on from that is sort of globally and sort of in the UK we're focused on. So, is there been an increase in the amount of people with inherited retinal disease like Stargardt?
Yeah, it definitely grows every year just from the growing population. I think that our ability to diagnose patients is improving as well. So that just overall increases the incidence of these inherited retinal diseases. In the UK, it's, I would say, roughly 1 in 2,000 people have an IRD. Globally, it's closer to maybe 1 in 1,100 or 1,200. And so that puts UK prevalence of inherited retinal disease around maybe 30 to 40,000 people.
Oh right, wow, that's yeah, it is getting quite. I mean, it is huge, isn't it? But then if you put that alongside AMD, of course, it's
Right.
kind
Yeah.
of fairly insignificant. But but as you pointed out during your talk, there's lots of people of working age and younger. So I suppose then, just to really nail down what dystrophy someone may have, macular dystrophy someone may have, it's very important to do genetic testing.
Yeah, absolutely. It's becoming the mainstay of an IRD specialist practice. We used to do a lot more diagnostic testing with electroretinograms, which a lot of patients are familiar with. It's a long and arduous test, and those are still actually quite useful. But genetic testing is more definitive, and we're starting to kind of redefine a lot of conditions based on the underlying genotype.
So you very much encourage people to have genetic testing when it's offered.
Yes, and you need, of course, proper, counseling before you get the testing and proper counseling after you get the testing with the results.
Yeah, I think it's very important. So, I mean, it's fantastic that there are some sort of trials now going on for sort of some treatments, and everyone's looking for that potential cure, aren't they? So, you mentioned a couple of trials that are in stage 2 and stage 3. So, have we got any? When we likely to see the outcomes of that, or is there any sort of interim sort of announcement?
Um, yeah, so that's a good question. If I had a crystal ball, I'd, I'd be part of
Yeah,
these teams. But the FDA is a complex and very intricate organization. These companies that are applying for FDA approval, even they themselves don't know. I mean, we're hopeful that probably within 1 to 2 years, there may be an approvable therapy on the market. It's looking like it might be a oral treatment, one of those oral treatments that I discussed.
yeah.
But that even that could be wrong, just depending on how the clinical trial results turn out.
Yeah, yeah, so your hunch would your hunch be? I'm not going to hold you down to this, of course, but that the oral treatments are probably the most sort of advanced at the moment, and it's likely that we'll be seeing some of those develop, or is there something else in the background that we don't
No,
quite
I
know
think
about?
it's the oral ones. Those are the ones that are in late phase 2 and phase 3. So those would be the closest to the finish line, so to speak.
Good, okay. Uh, oh, right. Okay. Sorry, I'm listening to my screen reader at the same time as trying to breathe, and sometimes that doesn't work very well. Just a sort of personal question, I suppose, to you. So, is there a really good bit of research that you like? So, is there an area of research within inherited retinal diseases that you're particularly interested in?
I mean, I give these talks on Stargardt because that is a really big focus of mine. I have so many patients with it, and there's such unknown and potential for discovery and development and ways to help these patients with Stargardt, such as yourself. Retinitis pigmentosa is another big area of research for me. So I wouldn't say specifically a particular mechanism of therapy or a particular drug, but certainly just helping all patients with these conditions and finding ways to make them better.
Yeah, I mean, it's really cool. I mean, I'm very aware about my own condition. I know that my maculas are no longer exist effectively. So,
Mhm.
my light receptors are gone. So I did smile when you mentioned, if I read this wrong, I'm sorry, but it's optogenetics. So that seems like a very exciting area for people like myself who are a bit further along and really starting to get some light reaction back into the back of the eye. So perhaps you could tell us a bit more about that.
Yeah, optogenetics, as I mentioned, it's a very complex area. The technology has been around for many years, but only being repurposed for the retina more recently. And the idea is to, allow those areas of the macula, like you were saying for yourself, that have degenerated to reactivate light sensing ability and send a signal back to the brain. It's still more preliminary, the research. I would say mostly phase 1, phase 2 trials. So we're not quite near the approvable clinical trials or approvable finish line, so to speak, for optogenetics. But I'm hopeful. It's more of a target for regenerative medicine rather than sort of stabilization of disease.
I must admit, I mean, it's very exciting, that area. It's nice to hear something was going on in those areas,
Yeah.
and sort of leading on from that, I suppose we all know about what happened with the RPE and stem cells with Peter Kofi, who sadly passed. But where are we at with stem cells? Do we think this is going to have an influence on treatments and
Yeah.
cures for Stargardt's disease?
This is one of those areas where stem cell technology, Stargardt can really benefit from research in macular degeneration as well. There's tons of stem cell, like retinal progenitor stem cells, embryonic stem cells for geographic atrophy, which is a similar type condition. And so, stem cell development is still very early on. I wouldn't say that we've really reached points where we can see reliable improvement in vision and ultimately patient outcomes in large phase clinical trials. So still waiting for that, but I think that certainly multiple companies in that realm looking for something that can help patients.
Yeah, again, it's another very exciting area. I think, I think it's brilliant. And finally, I suppose, just in your opinion, again, not going to hold it down, hold you to it. But do you feel like we're actually getting closer to a good and sort of influential treatment for Stargardt disease, leading to potentially a cure sometime in the future?
The word cure is tricky. I don't
Yeah,
love using that word
yeah,
because patients will hold you to that.
yeah,
But
yeah.
I will say something on the market that can potentially mitigate progression of disease. I would hope definitely in the next 5 years, something like that. Yeah.
That's awesome. So, anyway, so Dr. Kenneth Fan, really thank you for joining us for our conference this year. That's been a really interesting talk, and thank you for spending some time with us. Really, so thanks very much.
Yes, my pleasure.
Brilliant. Okay, thanks.